It is my privilege and pleasure today to be hosting Dr. Walter Jean, professor of neurosurgery at George Washington University, also director of skull-based surgery there, where he's going to be talking about using augmented reality to enhance our understanding of the middle fossa approach for vestibular schwannoma. So the focus of today's webinar will be on both the use of preoperative virtual reality for rehearsal, as well as the intraoperative augmented reality to allow us to, quote, see what we can't see during the operation. And we'll show progressively how we use the augmented reality in different stages of the operating room to identify individual important pieces of the patient's anatomy, again, to create kind of a 3D roadmap of where we're intending to go. Finally, we'll do a live drilling of a 3D printed skull representing what we would actually do if we're drilling the IAC in a typical middle fossa approach. So with that kind of as an introduction, I'd like to switch it over to Dr. Jean, where he's going to be going through the anatomy and the understanding and the indications for the middle fossa approach. Walter, take it away.
All right, let's do it. Everybody see my screen okay? All right. Yes. Thank you for that introduction, Rob, and thank you for the invitation to present here. It is an honor to do so, and it is kind of weird to be presenting a middle fossa approach to folks in the LA area, because after all, this is where it all started, right? I mean, we're going to talk about Bill House in a minute. So we're specifically going to talk about this middle fossa approach for the intracanalicular vestibular schwannomas. So Rob just told you about the use of the VR and extended reality system for teaching and patient engagement. This time we're really talking about using it for surgical rehearsal and surgical navigation. And one principle that I put a label on this concept, and I call it the Goldilocks Principle. We're trying to adhere to the Goldilocks Principle. What does that mean? It really means that we're trying to make things not too big, not too small, just right. So our surgical opening is not too big, not too small, just right, so that we don't compromise on exposure, but we can be minimally invasive at the same time. And the Goldilocks Principle for skull-based surgery really involves the 3 S's that I use to teach our residents: size, specificity, and safety. The size, again, not too big, not too small, just right. Specificity is location of the craniotomy and the openings. Not here, not there, not everywhere, just right. And of course, that all and then enhances the safety for the patient, the safety for the procedure. And vis-a-vis the augmented reality for middle fossa, really today we're talking about mainly about the specificity and the safety of the two of the 3 S's of the Goldilocks Principle. So let's go ahead and talk a little bit about the middle fossa approach. Again, 1961, first description by Dr. House in the LA area, of course, in the House Clinic now. The indications for the middle fossa approach is for vestibular schwannoma. They're mainly in the canal with a small CPA component. Now, you can do big ones too, but this is the indication that it was invented for and mostly used nowadays. Tumors with lateral extension, especially challenging for the retrosigmoid approach, are actually perfect for this. Now, there's a limit to that. You know, we talk about the fundal cap and how lateral it can go without involving the fundus. But laterally situated tumors that are challenging for the retrosig is perhaps perfectly suited for this. And then this is, of course, a hearing preserving approach, and it has very good data indicating its use for hearing preservation. So a typical example of the tumor is that one that we're going to talk about more in detail today. How good is it for hearing preservation? Here is from the House Clinic itself. It's a comparison between the retrosigmoid and the middle fossa approach. The mean decline of hearing is significantly better for the middle fossa approach than for the retrosigmoid approach after surgery. Same thing, the decline in speech recognition, there's still a little bit worsening of the hearing with either one of those approaches, even though they're both hearing preserving, but the decline is less so for the middle fossa approach, and is also statistically significant for the speech recognition. Facial nerve outcome and CSF leak rates are no different in this large series. This is a series from my training ground, the University of Cincinnati, with my teacher, Mario Penzak, and of course my friends, Mario Zuccarello and Ravi Sami, etc. And they said they looked at 63 patients from the University of Cincinnati data. The gross total resection rate was very high. and the hearing preservation rate was 71 with some residual hearing and 54 with serviceable hearing. And again, the facial nerve preservation rate is quite high as well. So in other words, it is a very useful approach for intracanalicular vestibular schwannomas that have very small CP angle component. In order for you to do this approach, you must understand the anatomy. That's the same for all skull-based surgery. But perhaps this one is particularly intricate because of the surface anatomy of the middle fossa floor, as well as the deep structures that are invisible, hidden by the middle fossa floor. So let's talk about the relevant anatomy on the surface of the middle fossa floor. First thing you need is the foramen spinosum in the middle meningeal. Inevitably, in dissecting towards the Holy Grail in this operation, you're going to encounter that, and that's the first thing you're going to see as a road-mad landmark, and you will have to coagulate and incise it. So that's the first signpost that we see on our journey towards the target. GSPN is very important. It is not only a landmark towards the target, but also a guide towards where you drill. When you don't use navigation, you need that very, very clearly delineated to know exactly where to start the drilling. You will use the third division of the trigeminal nerve as a landmark as well, especially if you do an extended middle fossa approach like a Kawase, but that's maybe a little bit further out for this particular one. That is the carotid artery that the arrow is on, and if the carotid artery is dehiscent, if the floor is very thin in those areas, one must be very, very careful not to drill near there or else you will hurt that. Now, it is on the lateral side of the GSPN, so you really shouldn't be drilling there because that's Glasscock's triangle, and that really shouldn't be in your field, but that's something to be good to know to avoid. And finally, colored in yellow here on the surface of the floor of the middle fossa is the arcuate eminence. That is a very good guide to the superior semicircular canal, and that would be important for you to get oriented towards where to drill to get to the internal acoustic canal. Now, that is just the surface anatomy. Much more interesting or much harder to learn is the anatomy that is now hidden by the floor. Here's a virtual reality rendering. This is the right side. Again, it's the same side that you've been looking at. Here's the labyrinth. There's the cochlea. There's the 7th to 8th nerve complex, and there's the aforementioned carotid again. So these are structures that are very important for the approach, but are hidden by the bone of the middle fossa floor. The labyrinth, of course, you need to avoid, otherwise you'd be doing a translab, I guess. But the superior semicircular canal is a very good guide towards the internal acoustic canal. The light blue is where, of course, the Holy Grail is for this. You need to drill towards that to expose the tumor, because after all, the tumor is on that nerve. And again, the deep blue where the cochlea is, that is something to avoid as well. And of course, the aforementioned carotid already mentioned. So those are the deep structures that some of which we're drilling towards, some of which we're trying to avoid. And that makes for a rather complex operation. And this is where our otologist friends make all their big bucks to know how to do and avoid those things. So the standard steps for the middle fossa approach, the craniotomy is rectangular to expose the temporal dura. I'm going to talk a little bit later about this. This actually, craniotomy needs to be a little bit taller than it is wide, especially if you have good guidance towards where the internal acoustic canal is. The reason for that is how the line of sight has to be almost from top to bottom. And we'll talk a little bit about that nuance in a little bit. The exposure to the middle fossa floor is next. You're stripping the dura mainly from a posterior to anterior direction. Your first thing that you're going to find is spinosum and the middle meningeal. You're going to buzz that. And then the next thing, hopefully, you'll find is the GSPN. You must not hurt the GSPN by going from anterior to posterior. It must be posterior to anterior. And then finally, identifying the GSPN, the arcuate eminence, and off you go. So here's a picture from the Roten collection. The craniotomy has been done. The dura is being stripped off the floor of the middle fossa. The middle meningeal is going to be somewhere in here. You can actually see the middle meningeal right here. Spinosum is going to be right there. And the GSPN is the second target that you will see on the way towards your drilling of the IAC. Now, identifying the internal acoustic canal, in other words, the precise drilling of the floor of the middle fossa to get to the tumor, is the hardest thing to do and the hardest thing to learn. because of how easy it is to get lost. Bill House, when he talked about this method, he talked about finding the GSPN and exposing the genicular ganglion and then following the first genuine facial nerve then towards the IAC. So like from a distal to a proximal way to tracing the facial nerve. And if you can trace the facial nerve, of course, then you'll find the IAC. Very few people do this now because if you expose the genicular ganglion, you can easily damage that, and you can have a very significant facial palsy. And I think most people would avoid this particular technique now because it is so easy to hurt the facial nerve. Unless you're an absolute expert, Dr. House invented the technique. Maybe in his hand is somewhat different, but in most people's hands, this technique puts the facial nerve in somewhat more jeopardy than the other techniques. What are the other techniques of finding the IAC? Hugo Fisch. You find the superior semicircular canal, and the IAC lies about 60 degrees anterior to it. So if you find the arcuate eminence, you blue line the semicircular canal, the superior semicircular canal, and then in front of it, 60 degrees, you will find the IAC. That's a technique that my friend Ravi Sami uses at University of Cincinnati. Perhaps the most common one is this one that was written by Garcia Ibanez several years ago. So this is the third way of finding the IAC now. First, find the GSPN, same as the House technique. Then you find the arcuate eminence, same as the Hugo Fisch technique. And now you bisect the angle. So here's the line of the GSPN. There's a line of the arcuate eminence and superior semicircular canal. You bisect that angle, that should land you right into the internal acoustic canal, and so on. Now, I don't know about you, but my eyes are not integrated with a protractor, and I can find the GSPN pretty well. I can sometimes find the arcuate eminence well. Sometimes it's a little bit fuzzy. Not in all people is the arcuate eminence very prominent. Now, I don't have a protractor that can bisect that angle perfectly, and so this is a complex procedure for me. All right, so logic dictates if we have the technology for navigating, why don't we use neural navigation to do this? And of course, people have tried this and been successful. These two papers are just some of the data saying that navigation is helpful to find that internal acoustic canal, and the measurements that they did was very good and whatnot. The problem, of course, with this, well, we'll talk about it later, but the problem is trying to find a three-dimensional structure, that is the canal, in a two-dimensional navigation plane, looking at a screen that has 2D views and trying to find the canal that way. It can be somewhat confusing and challenging. Now, the demonstration of the steps I'm going to do in virtual reality. So we're going to now rehearse the middle fossa approach, but with the help of all of our virtual reality and augmented reality objects laid in. So here is a video of this procedure on the right side of this patient done in virtual reality. Oop, let's go backwards and start. Oop, no. Okay, so we put a burr hole at the root of the zygoma near the floor, maybe just a little bit posterior of it. The bone flap, again, I'm beginning to think that it needs to be tall more than wide. So here's the bone flap. There's the floor of the middle fossa, as we saw before. Now, we've laid in the tumor. So you can see the tumor through the bone of the virtual reality space of middle fossa floor. And I'm not bisecting any angles. I'm just going right for it because I can see the tumor. And now the bone has been filled in a little bit more here. But again, we can, in rehearsal, we can fade in and out the bone and bring in and out the critical structures in the tumor. And we know exactly where to drill because of those fading in and out and all those precise locations. So we're completing the drilling now. We're widening out the canal. Now, in reality, of course, you need a little bit more anterior and posterior exposures to maneuver your instruments. You can't maneuver your instruments in the cylinder right off of that. But that pretty much says that's the amount of drilling that I should do. That's the precise location where I should drill with the addition of some more anterior and posterior exposure without hurting the cochlea and the labyrinth. And there you have it. That's my rehearsal for approaching the tumor and whatnot. So moving forward, after rehearsal, you can actually do the real thing. Now let's go back to this. What is the problem with navigation again? The problem with using navigation for this in the traditional sense is that you're trying to find three-dimensional structures in 2D. And don't forget, you are looking away from the operative field. So all the navigation systems that I know, even the microscope integrated ones, require you to put your pointer in something or your focal point of focus at something, and then you're turning your head to another screen to see, okay, where am I with that point? Okay, now you're coming back to the operative field and back and forth and back and forth. So that's one major issue that we need to solve. Now, what if we have X-ray vision? What is going on behind that wall? Okay, so what is going on below the deck of the middle fossa floor? If I can see the tumor through X-ray vision, and on top of that, if my X-ray vision lets me see through without having to tilt my head, you see, Superman is looking right at the target. He's not looking at a screen, tilt the head to the screen to see what's behind the wall. He's looking straight through the wall in the same visual field. So with that, it might be easier to find the tumor, to avoid the critical structures, and make this surgery, if not safer, and at least more efficient. So this is what we're going to try to do with augmented reality. And I am going to stop here. Now, what we're going to do is we're doing a live demo. We're going to pretend that we actually have the patient in the Hogue OR, and we're going to set the system. Robert is going to set the system. And we are, in fact, not going to use the house technique, not going to use the Fisch technique, and not going to use the Garcia Ibanez technique, but we're going to navigate and drill right at the tumor and see whether we can avoid it and find the tumor. So with that, I am going to stop sharing my screen and turn it back to Rob for a second.
Awesome. Thanks, Walter. That's a great overview. And just to kind of, add on to your point about, two-dimensional navigation versus, 3D, 360 augmented reality, I'm a big wilderness guy. So when I'm out in the wilderness, I've got a topo map and a compass, and I'm kind of drawing bisecting lines to figure out how to get from here to there. Except now in the modern era, I can have a GPS, which has a three-dimensional representation of the mountains. And it's like, rather than trying to, triangulate the position, it's like I look up, I look at the 3D map, and I'm like, I want to go there. And it just leads me in the direction. So, it takes a lot of the guesswork out of it. Now, this doesn't say that, we become totally reliant on these. Of course, our understanding as skull-based surgeons, our understanding of the 3D anatomy is critical. However, when we can improve or augment that using modern technology and take our baseline understanding of the kind of general anatomy or the, ideal anatomy of the middle fossa floor, and then augment that with this patient's specific anatomy, it really does enhance our ability to, like you said, go right for the target, get straight for the goal. Because I also don't have the ability to tell in my mind, the difference between 55 degrees and 60 degrees. And in fact, it's known that the ability of the human eye to detect, degrees is about 7 or 8 degrees. So, if you're off by 7 or 8 degrees, you may end up in the wrong direction if you're using one of these techniques, which requires you to eyeball, an angle or a line of sight. So with that, we're gonna get on to the live portion of the demo here. I'm just gonna kind of showcase how the different technologies interplay with each other and integrate. Essentially, in order to perform this augmented reality, we need 3 main components. So the core component of the system is the surgical theater Sync AR. This is the system which renders the patient's own images, the CTs, the MRIs, renders them in a 360 model, and then is able to project them into the eyepiece, the oculus of the microscope for heads-up display. However, in order to do that, we also need to have the stealth station navigation. So we have a stealth station 8, which is tracking the position of the patient, of course, in reference to their scans, as well as we are using a Zeiss Kenevo microscope. This can also be done with the Leica Arveo microscope. In addition, in order to having the Stealth Station 8 and either the Leica or the Zeiss microscope, what you need is the ability to track the microscope itself. So that's an add-on for the Stealth Station, which you can get, which allows you not only to track the X, Y, Z position of the microscope, but also the roll, pitch, and yaw, as well as zoom, magnification, and focal depth. So for those of you that have done, live microscope tracking, that it's tracking exactly where the focal point of the microscope is. It is this ability to track exactly what I'm looking at through the microscope that enables the Sync AR system to then take that same 360 reference scan and show me where I'm looking on the 360 model in reference to what I'm actually seeing in a live scan. We're going to demonstrate how we do that, how we verify the accuracy of it starting at the beginning, and then how we use it throughout the case, kind of bringing it out to give us, waypoints as we do using a GPS for navigation. So as we move on to the live demo portion, I'm going to come over to the microscope here and take a look. So I've got the microscope set up here, and the first thing I'm going to do as I bring this in, we've already registered the patient using the standard technique of facial registration. Generally, we want to make sure our accuracy or our registration error is less than 2 millimeters. And then if we bring in the augmented reality overlay, we can see the overlay and determine whether or not the 360 overlay accurately matches the 360, the 3D printed model in front of us. So what I'm looking at here is the root of the zygoma to ensure that the registration of the microscope and navigation is indeed accurate. Now, if I want to kind of fade it down so it's less opaque, I can use the foot pedal. So I've got a foot pedal that's able to bring the 360 model in and out. And if I bring it all the way up, I can make sure that indeed the root of the zygoma is accurately represented on the 360 model. In other words, I'm verifying that the baseline registration of the stealth station is accurate. I can also bring in the navigation probe as another method of demonstrating that it is indeed accurately tracking. And you can see if I bring the opacity down, the virtual probe accurately overlays on top of the true probe, as long as I don't get something in the way of its line of sight. So as I roll it around here, you can see it's tracking the position there. Okay, so what I'm doing now is, I'm looking through what is our simulated craniotomy. So it's a 3D printed head with the craniotomy that's simulating the craniotomy that you made for this actual case. And I can see the relevant anatomy on the floor of the middle fossa. I'm bringing it into focus here so that the focal depth is just at the level of the superior semicircular canal. So you can see there, as I'm clipping the white outline, I'm starting to cut into the superior semicircular canal. I'm focused there essentially right on the arcuate eminence. And what I want to do, of course, is make sure I'm going, anterior and deep to that. And as I follow this around, I'm going to get the view of the microscope such that it's right in line with the IAC. But I can then use that to guide my drilling. Okay, so now I'm going to take the overlay out and see, this is what I'm seeing here in the model. And you can see how the AR overlay allows us to augment or improve our understanding of the middle fossa anatomy. In this particular patient, even though it's 3D printed to be very accurate, the arcuate eminence is not really that visible. So we are using the AR overlay to improve our understanding of that. Of course, if you kind of take a closer look here, we're looking at the superior semicircular canal, and we're going to be directing our drilling along here. This is the tumor here. So we're going to be aiming our drilling right along here. We're using the AR to determine that this is the position of the internal auditory canal. You can see how accurately the AR overlay lines up with this vessel here. You can see the IAC coming through the foramen lacerum over this way. And of course, we're targeting our drilling right along here in the IAC. Of course, I'm starting at the deep aspect and working from medial to lateral. But now I'm really focused just on where the tumor is and on identifying the roof of the IAC.
And you can also bring in and out of the labyrinth and the cochlea just for references.
Exactly.
If you so choose.
And I can show that here as we. So making sure we are medial and anterior to those structures. You can see now the tumor starting to come into view, or the dura over the tumor starting to come into view. There we are, starting to see a little bit more. As I work anteriorly and posteriorly, I'll be able
This
to, as Walter said.
So you're getting there, and it's very reassuring that everything is lining up perfectly, and you're drilling towards the target with absolutely no hindrance.
And you can see how, as you said, Walter, without having to, kind of create these imaginary lines in your head, once I've verified the accuracy of the overlay, I can simply go straight for the target, which is what we see here represented. And as I would drill further, which I'm not going to torture you guys by continuing to drill around to create a circumferential approach, but essentially going right for the goal here, because we know where it is really allowed. The ability is allowed to us by this heads-up display and synchronization of what I'm seeing visually within the microscope, and then synchronizing that with the 360 overlay, which allows me to kind of put all the information in my head in one place, as opposed to kind of looking back and forth between the 2D navigation screen and trying to find that XY point on the uneven floor of the middle fossa.
For completeness, we're going to show you the rest of the procedure, how it proceeds, how it goes forward. And this is a video that we published a year ago or so, and we have permission from TEMA to show it. Just to kind of, again, for completeness, show you the intradural portion of the procedure. So this is a patient that presented with this, with a little bit of hearing loss on the right side, new symptoms of dizziness and headache. And the audiograms, usable or not, this hearing, it's arguable, but he wanted to preserve it, and we thought it was possible, perhaps. At least he can use it to tell the sound of direction if he's not even if he's not using that ear very well. Again, the indication of the middle fossa approach is well described already, and we've already talked about that today. Well, with the one addition to say that we do use a lumbar drain to dissect the dura, because it is, we think that it relaxes the brain a little bit better. So here's the positioning and the traditional incision. Again, the bone flap, I think, is more tall than wide nowadays. There's no point going through this again. I've showed you already in real the other way. So here's the real demonstration of the microsurgical technique: stripping the dura from the floor of the middle fossa from a posterior to anterior approach, finding spinonosum, coagulating it, and then finding the, excuse me, there's a spinosum, get rid of it, pack it, whatever you do, finding GSPN at the start of it right there. And then that would be the signpost. Now, this is pre-AR days. The technology is, after all, only about a year old. And so we did not have AR here. What we had was a very skilled otologist, my partner, Jeff Kim. And he located the arcuate eminence semicircular canal superior and then start drilling towards the IAC. Starting near the IAC, of course, you have to be very, very cognizant that the facial nerve is going to be anterior superior to you. And boom, 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 there it is, find it in the canal. And you widen it both anteriorly and posteriorly so that you have room to maneuver the tumor out of there. You can't go too much further lateral because of the ampulla of the vestibule. Opening the dura over the IAC, and then finding the brain stem first, and then looking more laterally to find the tumor. This is opening the canal more laterally now. The tumor is well visualized. And there it is, the tumor. Now, the facial nerve is going to be just anterior to us. And initially, there was absolutely no separation, very, very, very stuck. Right there. Start debulking some of the tumor just to make room for the dissection to save the facial nerve. And finding the facial nerve at the stem right now, right there. Now you have the whole course of the facial nerve, the relevant course of the facial nerve, completely exposed. Now you try to get some separation of the tumor from posterior, and you're trying to dissect it from medial to lateral, always medial to lateral. And then eventually we'll find some separation with lots and lots and lots of patients. This is a procedure that you cannot rush. It dissects off the facial nerve at its own pace, and speed is not a premium here. After all, it's a small tumor. So finally, with our Rosen needle, we're finally getting a little bit of separation there. And then you can mobilize that tumor away from the facial nerve, posterior to the nerve, and then again, debulk it more. And then just to skip forward a little bit, there is a little bit of residual in the lateral part of the canal near the fundus. You can use an endoscope to look at this piece. Most of the time we do so these days, but that was taken away by the curette, and we got the result here. We got a total resection here. There's 7 in continuity, both electrophysiologically as well as anatomically. There's 8 in continuity physically, and we're happy with it. And then you, of course, you take the rest of the tumor out over the cochlear nerve, make sure you don't leave anything lateral. Again, the endoscope can be very helpful here. Checking 7, checking 8, and then finally closing. Wax up, make sure all the air cells are waxed, and the rest of the closure proceeds in the usual fashion. So that is the microsurgical portion of the procedure. This was done before AR, and so we don't have AR for that, but that was the show of the more traditional way of getting to the canal. Okay.
So thanks, Walter. That was great. A great demonstration of the surgical technique there. And you know, before we open it up to the audience for questions, you know, I kind of wanted to ask a question of you, because this is something that sometimes bugs me. You know, my background is in neuroanatomy. Even before medical school, I was teaching neuroanatomy, publishing neuroanatomy. And, you know, when I'm speaking about this and demonstrating the benefits of augmented reality, one of the major things that I kind of am try to emphasize is that, oh yeah, you know, the value of understanding the 3D neuroanatomy that this adds. It adds another layer. Number one, that in this particular patient, but also just, you know, reinforcing your situational awareness. And one of the kind of comments that I always get from, you know, my more seasoned colleagues, you know, say like, you know what, son, like when you really know how to do this procedure, you won't need fancy gadgets like that. You'll just be able to kind of, you know, go straight forward. And I like, you know, I can't really wrap my head around that. Again, I feel like I have at least an average understanding of skull-base anatomy. And it just, you know, it's one of those things that from a more, you know, you've got obviously a lot more experience. I just wanted kind of your take on this.
Well, we talk about this ad nauseum, and I always bring up the example of neuronavigation when it was first a young technology. Everybody said, "Oh, you don't need." We've found tumors all these years. You know, we never had trouble with it. Why? You know, there's no data saying that navigation is better than no navigation. But of course, everybody has adopted navigation. It's almost criminal if you don't use navigation nowadays, even for more routine cases. So there's no particular. You know, you don't really need data to show you that something is useful. And even if you're an experienced surgeon, you've found the IAC 100 billion times, you know, add a layer of security, add a layer of safety, why not? And it might actually make you more efficient. So you know, last operation you did was 2.5 hours, now it's down to 2 hours because you had an additional piece of technology to help you. Why not? I mean, it's helpful. So I think the naysayers will all come towards the technology as the technology matures. The other thing is, you know, there's a webinar soon about orbital surgery by neurosurgeons. You know, neurosurgeons need to reinvent ourselves every decade or so. You know, we adopted endovascular techniques from the radiologists, and now we're into stroke. Not saying that we're going to push our otology colleagues, whom we all partner very, very well with, but you know, in a situation where maybe the otologist is not available, you know, we need to have these skills, and you adopt these skills not only to maybe vestibular schwannoma surgery where you always have an otologist, but maybe you adopt it for the drilling in the middle fossa in general towards aneurysms and tumors of the brain stem and the mesocephalon pons, etc. So again, this technology is always helpful, no matter what stage of career you're in, how expert you are, and what kind of surgery will you do.
Well, that makes me feel a little better, at least. We got about 10 minutes left, and I'd like to open it up to Sunny. Do we have some questions from the audience for Dr. Jean or for myself, about the approach or about the technology or how we kind of use this in our daily practice?
Yeah, absolutely. I'd like to facilitate some of those questions. So I'll start with Dr. Jean. What are some of the other pathologies that you're using this technology for, and other pathologies, and how you're finding it valuable for other areas?
In terms of the middle fossa floor, you can even go further than just vestibular schwannoma. We're using this technology for petroclival meningiomas, for cavernomas of the pons. There is one video that's soon going to be published that we use this to avoid the cochlear and eye internal carotid for drilling of Kawases towards a posterior clinar meningioma, for example. And of course, in other areas, this AR overlay concept really helps you to follow the Goldilocks principle. You make this craniotomy exactly how big as you need because you rehearse how big you need it. Now here we didn't show the template technique, but oftentimes we would rehearse a craniotomy, frontal, temporal, whatever area. You would rehearse that and use and save that and bring that opening as an AR object, bring that opening as a navigated augmented reality object to follow as a template so that your opening of the bone is exactly how big it is. I hope that answers that question. I noticed Dr. Giannotta in the audience. I don't know whether he can hear me or not, whether he's paying attention to this, but here's someone who has a experience in the middle fossa technique way over my head. And in fact, I was talking to his former partner, Rick Friedman, on another webinar about middle fossa just last week. I wonder whether Dr. Giannotta has any comments. And as we follow through, let's see whether he wants to say something about the tech. Any other questions, Sonny?
Dr. Giannotta, if you'd like to mention anything, please feel free.
Can you hear me? I can't talk.
Yes, we can hear you.
Great. Well, thanks to both of you. This was a great presentation. I'm jealous because we don't have this technology. I've seen it in its early phases, and Rob would remember that the technology with the model for its use was always an aneurysm surgery. In fact, Neil Martin championed that.
Yes.
This the model that techniques that you've shown today is, I think, is even more germane because of the complex bony anatomy. And for me, having worked with everybody from Bill House all the way to a neurootologist 2 months out of their fellowship, you get spoiled. Walter, you would know, you get spoiled with working with advanced neurootologists who, as Rob says, can do this operation in their sleep and can't imagine why anybody would need any kind of navigation. But yet, we're also we also have the job of teaching the ENT residents and the neurosurgery residents.
Exactly.
Right? What better use of this technology so that with each case they go much farther up the learning curve than, let's say, drilling 6 temporal bones in the lab and then watching their professor do it. So your points are well made. I really totally agree. I wish we had this technology here because we still have a fairly high throughput, even though Rick's gone, we still have a fairly high throughput practice here, and the efficiency of knowing that when I'm in one room and the drilling is going wonderfully in another room, right, your efficiency goes way up and you can get a lot of cases done per day. But yeah, congrats to both. This was a very nice webinar.
Well, thank you for that, Steve. And there you go, Rob. Here's someone with experience to the max, saying that it is useful. Yeah. So there you go.
Yeah, Steve, we really appreciate your comments on that, because as a kind of starting to get towards the middle of my career, it's always like, am I really that dependent on this? And it's like, no, it's an additional tool that we can use to make to make the surgery safer. And I don't have the pleasure of treating residents or teaching residents here, But this is always kind of one of the best use cases I would have imagined. If the residents are saying, okay, put me in, coach, like, all right, show me you can do it on the VR and not drill into the semicircular canal or drill into the carotid. So, once they kind of get the ability to do that again and again, and, as compared to a cadaver-based lab, it's not each time you do it, you have to kind of reset or flip it over. You just, press reset and do it again. So yeah, that's really valuable to have your insight. Thanks so much, Steve.
Sure. There is one more question, whether there's any liability to using this technology. I'll answer that several ways. One is that there is data that says that if your visual field is very crowded when you're operating, it could be very distracting and whatnot. There's data coming out of England with regard to that. My answer to this is that we put in structures that we designed ourselves to put in, and we take them out whenever they're not necessary. So they're not constantly there to bother us when we don't need it. We only need the labyrinth when we're worried about whether we're close to it or not. So that's that. The other liability is that the technology somehow fails and you're dependent on it. So yes, the technology is great. It's a great tool. But you cannot get to a point where you're completely dependent on it, because machines do break and navigations break. And so you probably shouldn't be dependent on it, even though it's a great tool to have and a great tool to learn from and so on. Those would be the only liabilities I can see to this. I have to confess that early on in my career, partnering with my otology friend, we had one metal fossa that we actually whiffed on. We couldn't find it. We somehow or another, we got all lost and couldn't find it. I think with this technology, it's impossible to not find it. If the green tumor is right in front of your face and you're drilling towards it, I don't see how it's possible. I suppose it still is, but I can't think of a scenario where it's easy to miss the tumor. So I think, my God, this is a revolution. So that's
and I would just add that, the liability, is the same as we always have in surgery. And we, use navigation to blindly insert a shunt, into the ventricle without any other landmark sometimes, or we use, other forms of guidance, just based on navigation alone. So, including, DBS catheters are inserted, just that way, using a frame and navigation. So there's always a chance that the navigation is off. But the additional ability afforded by the 360 AR overlay is you can actually check that on a known anatomical structure, especially when there's a known bony landmark like the root of the zygoma. Once you're there, unless somebody moves the navigation arm, that you can be pretty sure that what you're seeing accurately represents the patient's own anatomy.
Fantastic. Thank you, Dr. Lewis. Thank you, Dr. Jean. Really a pleasure being able to have you share your experience and your knowledge. I'd just like to hand it off for any closing remarks. Dr.
Walter.
I think this is a great use for this technology. I use this weekly, if not daily, and hopefully this would produce a lot of scientific knowledge coming out of this as well. We're finding new uses of the technology, because as with everything, we're gifted this new shiny toy and we're only learning its potential. And every day we're finding new ways of using it. So I hope to be able to share all that with our audience in the future. Rob?
Oh, no, that's, yeah, I totally agree with that. And, kind of as we evolve and adapt to our use of the technology, also the technology is evolving and adapting with us. So we're constantly kind of feeding back and saying, I'd like to see this, updated this. We just implemented a wire mesh as opposed to a solid view of the tumor. So you can kind of, if you'd rather see the tumor as a wire mesh, you can see through it. But as our understanding of how to use this technology improves, I think the number of use cases or where it's most useful will expand. I would just like to say thanks to Dr. Jean, to Walter, my friend, for being here with us today, for sharing his immense knowledge of the skull base. And thanks to Dr. Giannato as well for his comments. And we'll see you back next time from Hoag Hospital, where we will continue our series AR in the OR.